This presentation deals with professional medical ethics, and specifically boundary crossings and boundary violations. Most clinicians are not well informed about professional and ethical boundaries. They are often unsure, puzzled, lost, confused, unclear or baffled. Understanding professional boundaries and behaving ethically is paramount to patient safety. What is a professional medical boundary? A medical boundary may be interpreted as the edge of appropriate professional behavior, the transgression of which involves the clinician stepping out of the clinical role, or breaching the clinical role. Medical boundaries define the expected and accepted social and psychological distance between clinicians and patients. They are derived from ethical treatise, cultural morality, and jurisprudence. In the late 1800s, Sigmund Freud was very concerned about sexual transgressions among his trainee physicians. For instance, Dr. Carl Jung was clearly over-involved with a lady called Sabina Spielrein. Dr. Sander Ferenczi was analyzing a patient, Elma Paulos, and he fell in love with her. But Elma was the daughter of Dr. Ferenczi's mistress, Gisela Paulos. Dr. Wilhelm Stekel was well known as a seducer of women. And Dr. Ernest Jones indicated in a letter to Freud that his common-law wife, Locan, had been a patient of his as well. Freud was particularly concerned about the devastating impact of transference and counter-transference on his trainee doctors, and he warned his trainees about potential transgressions of professional boundaries. He stated, presumably to his trainees, that out of your vulnerabilities will come your strength. What is the difference between transference and counter-transference? Transference is generally thought of as the redirection of a client's feelings from a significant person in their life to the clinician and is mostly unconscious. Counter-transference is the clinician's feelings toward a client and depending on the clinician's sense, knowledge and experience, may or may not be conscious. According to the American Medical Association, the American Psychiatric Association, and other medical organizations, any relationship between the clinician and the patient that causes harm is unethical and thus prohibited in the workplace. Professional boundaries are there for a reason. But they can be pushed by either the clinician or the patient. However, the clinician will always be blamed for boundary transgressions. Why? Because the clinician's duty to the patient is a fiduciary one. The word fiduciary is derived from Latin, meaning trust. A fiduciary is one who stands in a special relation of trust, confidence or responsibility in his or her obligation to another. The clinician has two duties. 1. A duty of prudence to act with care, skill and diligence when treating a patient. 2. A duty of loyalty and exclusive purpose to act in the patient's interest, benefit and safety. Definition of boundary crossing and violation. The boundary crossing represents a non-severe departure from commonly accepted standard medical practice. It could benefit the clinician or the patient. The boundary violation denotes the exploitation or misuse of power in the professional relationship. It occurs when clinicians use their position of trust and authority for their own pleasure or benefit, or for the benefit of others. A boundary violation is unethical, can be harmful, or potentially harmful, to the patient, and is often illegal. For example, the tennis player must serve with the foot behind the baseline of the tennis court. If the player's foot transgresses over or beyond the baseline, that constitutes a faulty serve due to the foot crossing. When a clinician crosses a boundary line, that is considered a non-severe departure from standard medical practice. For example, a personal phone call from a dermatologist or a gastroenterologist, whose practice style is focused on physical ailments, might be judged as uncommon and questionable. If the call benefits the clinician personally, that may represent a boundary crossing. On the other hand, personal phone calls may be common practice for many practitioners, such as clinicians in a small rural community, psychiatrists and mental health workers. Those calls do not represent boundary crossings. Here is a boundary crossing that benefits the clinician. When a clinician thinks, "I want to hold your hand," and then acts on his or her feelings, that is a boundary crossing. The clinician is acting for personal good. That would be considered unethical. In contrast, boundary violations represent major unethical behavior. They involve 1. Misuse of trust and authority. 2. Exploitation of the clinician's power, and 3. Harm to the patient. Sexual contact is both unethical and illegal. Comparing boundary crossing versus violation. A boundary crossing is, usually benign, occurs in isolation, attenuated, and discussable. A boundary violation is, usually damaging to the patient, tends to be repetitive, egregious, and discourages discussion. The areas of boundary violations include 1. The role that the clinician is playing. 2. Time spent together. 3. The place and space of the meetings. 4. How much money was spent. 5. Exchange of gifts and services. 6. Type of clothing, such as seductive. 7. Language used, for example endearment. 8. Self-disclosure by the clinician, and 9. Physical contact, sexual or not. Clinician boundary violations include sexual misconduct, drug abuse or diversion, inappropriate use of social media, misrepresentation or falsification of credentials, financial irregularities, disruptive behavior, and failure to adequately obtain informed consent. Clinicians must practice medicine ethically. They are held in great esteem and respect by the society. Their behavior toward patients must be consistent with societal norms and culture. They are bound by the Hippocratic Oath to maintain professional boundaries, which are central to patient safety and well-being. The clinician's ethical attributes include competence, ethical behavior, public trust, accountability to the patient and the public, and advocacy for the patients, thereby preserving public trust of clinicians. Legal and ethical agreement. When the physician-patient relationship is created, two contracts or agreements are entered into. 1. A legal contract to treat the patient in accordance with the standard of care, and 2. An ethical agreement, or covenant, which protects the space that must exist between the physician and the patient. This covenant controls the power differential in the physician-patient relationship, and allows for a safe connection based on the patient's needs. Physicians have an ethical obligation to care for patients with beneficence, non-maleficence, and confidentiality. The clinician's behavior toward the patient should always be initiated and maintained with the patient's best interest in mind. Boundaries issues are disruptions of the expected and accepted social, physical, and psychological boundaries that separate physicians from patients. The therapeutic relationship between a clinician and a patient is established solely with the purpose of therapy. Whenever this relationship deviates from its basic goal of treatment, it becomes non-therapeutic. For example, in psychiatry, the therapeutic relationship is prolonged and more personal as many confidential matters are discussed. Thus, there is a likelihood of developing strong emotional bonds, which may lead to non-therapeutic activity. Boundary violation research. Researchers generally examine a narrow range of behaviors and precludes comprehension of the fully prevalent boundary transgressions. It restricts the creation of evidence-based practice guidelines and meaningful legal advice. It leaves physicians more vulnerable to avoidable lawsuits. It restricts full understanding of the impact of subtle behaviors on patients, and it limits research on treatment and outcome data. There are a number of unanswered questions. How do legal specialists define problematic behavior in the courtroom? How does one advise boundary violators on risk management and malpractice prevention strategies? How do forensic specialists, both psychiatrists and non-psychiatrists, provide treatment recommendations and determine long-term rehabilitation? Boundary violations comprise three categories. 1. Non-patient violations, for example, sexual harassment of co-workers, over-involvement or romantic relationships with staff, and prescribing for non-patients. 2. Patient non-sexual violations, such as inappropriately prescribing narcotics to patients, inappropriate touching of patient, not for medical purposes. This includes hugging and arm around shoulders. Inappropriate comments to the patient, not for medical purposes. For example, "I would sure enjoy spending an evening with you," or "going to a concert with you." Inappropriate behavior during examinations. For example, having no attendant present, kissing a scar, or being overly interested in the patient. Inappropriate clinical decisions. For example, scheduling a patient for last session of day and extending length of visit at no extra charge, and dual relationships, for example, multiple roles between a therapist and a client, such as having friends, employees, or students as patients. 3. Patient sexual violations, such as sexual intercourse with current or former patients, or sexual activity, but not intercourse, with current patients. The consequences of boundary violations include: 1. Risk of injury to the patient causing loss of trust in the clinician, fear of seeing other clinicians, depression with termination of relationship, guilt and anger, anxiety, sexual dysfunction, marital disruption, and possible psychotic reaction. 2. Risk of clinicians' ethical violations, such as dishonesty about mental health dangers to the patient and non-therapeutic effects of boundary violations, conflict of interest in satisfying the clinician's emotional need, conflict of interest in failing to exercise impulse control. 2. Risk of legal violations, for example, medical licensing board accusations, intentional tort of sexual battery and possible punitive damages, civil action of medical negligence and negligent infliction of mental distress, and criminal prosecution for sexual battery, even though the patient is a willing partner. Boundary violations, risk factors and triggers. The patient's risk factors include seduction, borderline personalities, manic or hypomanic behavior due to bipolar disorder or schizophrenia, patient going through a relationship discord or breakup who are vulnerable, delusions or fantasies involving seduction of the therapist, history of sexual relationship with prior therapist, suggesting a meeting outside the clinician's office, and patients who give presents. The clinician's risk factors include going through a relationship discord or breakup, being lonely, having delusions or fantasies involving seduction of the patient, being hypersexual, having a prior history of sexual acting out, and having poor impulse control. Clinicians who are boundary violators are generally in their 40s. Between 4 and 9% of U.S. physicians commit boundary violations. About 2/3 of the offenders are married. Prescribing violations constitute the most frequent type of transgression, followed by sexual intercourse with a former patient, and sexual intercourse with a current patient. Psychiatrists represent the greatest percentage of violators, followed by family practice and internal medicine doctors. More physicians presenting with boundary violations are mandated for evaluation and reported a history of childhood abuse, sexual or physical. The violators' diagnoses include physicians with mood disorders, adjustment disorder, anxiety, substance dependence or abuse, personality and sexual disorders. The physician's explanations for violations are mostly unknown. Some attribute violations to marital or relationship problems or being in love with or dating the patient. Some had substance abuse or sexual addiction. Boundary violators who engage in patient sexual violations are often referred for evaluation by the state medical board, peers, or attorneys. Some are self-referrals. They have significantly more legal actions taken against them. About 83 to 90% of monitored physicians have no further violations at follow-up, and over 85% have an active and unrestricted license. The duration of monitoring spans up to 4 years. About 59% of the violations were sexual. The rest involved sexual harassment, sexual comments, or sexually explicit discussions with co-workers or patients. Boundary violators tended to be older men. The ethical principles involved in boundary issues include: 1. Respect for the dignity of the patient. 2. Respect for the patient's authentic goals or choices. 3. Patient autonomy, which fosters independence, separateness and self-direction, and 4. Self-determination. The principles are central to the perseveration of the ethical boundaries. The fiduciary relationship adds altruism, beneficence, non-maleficence, and compassion. These concepts add honesty, trust, sincerity without reserve and loving care in the therapeutic setting. The clinician's personal gain should not result in exploitative situation and damage the principles of neutrality and abstinence. The slippery slope concept. The clinician must define the therapeutic territory and create safety for the patient by establishing clear professional boundaries which must not be ignored. Keep in mind that the clinician is always responsive, even if the patient is willing. If a minor violation does occur, it is better to transfer the patient to a colleague. Typically, a boundary violation starts small, then becomes incrementally problematic. The dyad starts sliding down the slippery slope. How do licensing boards review boundary violations? 1. The reviewer would try to determine whether the role played by the clinician had been reversed with the patient. Is the clinician benefiting personally? 2. The reviewer examines the quality and quantity of time spent with the patient. Lengths of time spent with attractive patients versus unattractive ones. Patients scheduled outside of regular hours, given special late appointments, or offered more frequent follow-up than is medically necessary. 3. Where was the patient treated? Office, bedside, or at home? Were all patients treated similarly and charged the same for similar contexts? 4. Did the physician give the patient gifts, consumer goods, generous prescriptions or excessively large amounts of drug samples? Did the physicians accept gifts or favors from the patient? 5. Did the clinician and the patient start become friendly or have business relationship with a current patient? 6. Did the clinician dress formally? Did the patient dress seductively during treatment? How was the patient addressed? Was the language used formal or endearing? 7. Did the clinician impose his or her ideology, for example being against inter-religion marriages, or being pro-life? Was touching of the patient necessary for the diagnosis of the patient? Did the physician explain why touch was necessary? Did the physician socialize with the patient? 8. Did the clinician have a conflict of interest? Conflicts of interest occur when professionals find themselves in a situation in which regard for one duty leads to disregard of another or might reasonably be expected to do so. 4 elements appear in all boundary violations. 1. Role reversal. 2. Secrecy. 3. Double bind, an emotionally distressing dilemma in communication in which an individual receives 2 or more conflicting messages, with one negating the other. Example, do not do X, or I will punish you. 4. and indulgence of professional privilege where the clinician divulges confidential information. These elements are particularly notable in sexual abuse of patients by physicians. Sexual misconduct usually begins with relatively minor boundary violation. It often shows a crescendo pattern of increasing intrusion into the patient's space that may culminate in sexual contact. A direct shift from talking to intercourse is quite rare. The slippery slope is the characteristic scenario. A common sequence involves the following. A. Transition from last name to first name basis. B. Personal conversation intruding on the clinical work. C. Some body contact, for example, pats on the shoulder, massages, progressing to hugs. D. Trips outside the office, then, sessions during lunch, sometimes with alcoholic beverages. E. Then dinner, movies or other social events, and F. Finally, sexual intercourse. How to prevent boundary violations. Discussions with the patient are important. 1. Strict instructions about boundaries, in highly risky situation. 2. Discuss with patient the seductive behavior, and 3. Refer patient for psychiatric evaluation or treatment if issue is not resolved. Discussion with peers and consultants are helpful. 1. Discuss concerns about patient behaviors, the clinician's observations and personal reactions including countertransference, and 2. Get advice about management of patient transference and risk of boundary violation. Counseling or therapy for the clinician to address anxiety and fear of acting out, failure to manage boundary violation risk, and actual boundary violation. If a boundary violation occurs, the physician should seek immediate legal counseling as well as therapy. Counseling or therapy for the patient is recommended if the patient is having difficulty dealing with transference issues, for example, continues to be seductive or to have fantasies. Other psychiatric issues become apparent, for example, the patient shows diminished impulse control, paranoid ideation, or suicide threats. Record keeping and tape recording. Consider tape recording sessions if patient is seductive or possible boundary violation situation. Clinicians may discuss tape recordings with peer or supervisor. Notifying the patient that a recording is being made is required by law, Penal Code Section 632. This can show patient's willingness to disclose information, especially in psychiatry. Other measures by the clinicians to prevent boundary violations include 1. Not wearing seductive clothing. 2. Carefully monitor your language to avoid saying anything to patient that could be misconstrued as inviting an inappropriate relationship. 3. If the clinician perceives a risk of boundary violation, try to keep a member of office staff in attendance during all physical interactions with the patient, and consider terminating care of the patient. The following are tips to maintain boundaries in clinical practice. 1. Stick to the therapeutic contract and ethical agreement. When invited to do something unusual, ask, "Is this what a physician does? Is this for my personal benefit or for the patient's?" The clinician should resist requests by patients to stray from the therapeutic contract. 2. Work in the office. Do not take patients outside the office. Home visits should be chaperoned, and behavior therapy protocols that include outings must always be within standard practice. 3. Never worry alone. Consult with a colleague, supervisor, or mentor before questionable actions can occur or after something questionable has occurred. And always document your consultation sessions about patients. 4. Be emotionally present. Do not make a promise to the patient that you cannot keep. The clinician may fall ill or may have a family emergency. 5. Do not avoid personal questions from the patient. Explore therapeutically a patient's personal questions about the clinician. 6. Know the protocol for gift giving and receiving. Treat a patient's gift as an opportunity to explore. Document your reasoning for accepting or not accepting a gift, and discuss the reasoning with the patient. And avoid giving gifts to adult patients. If the clinician gives a patient a relevant book or article, document the reasons for supplying the book or article. 7. When communicating with patients, be cordial and polite. But do not sign letters, cards, or emails with love, even if the clinician does so with everyone else in his or her life. 8. Do not use terms of endearment. Communicate the caring and concern by always keeping a focus on the patient's needs and issues first. But do not tell a patient that you love him or her, even if you do. 9. Remember to document. The clinician should thoroughly document the incidents that seem questionable regarding boundaries. Failure to do so suggests a cover-up. Use the 3 Ds, demeanor, documentation, and debriefing. For example, if a clinician gives a patient a ride to the bus station in a blizzard. 1. Keep a professional demeanor in the car. 2. Document the situation and your reasoning, and 3. Debrief it with the patient at his or her next therapy session. In conclusion, physicians benefit greatly from education about professional boundaries, especially sexual boundary misconduct. A preemptive approach is better than a post-violation intervention. The physician holds the balance of power over patients, staff and students. Mutual consent is not recognized as a defense for the physician. Emotional vulnerabilities of the patient and the physician are at the core of boundary violations. Self-care by the physician is critical to prevent hazardous romantic relationships.